present our first case, so let's get into it. All right, so we have a 76-year-old, that's down here, 76-year-old nonverbal female with atrial fibrillation on apixaban, type 2 diabetes, hypertension, CKD, CAD, chronic respiratory failure of unclear etiology with a long-standing trach and PEG on a ventilator, presenting from her nursing home with bright red blood from her PEG. When she arrived, she was fairly unstable, had a Tmax of 90 degrees Fahrenheit, was being rewarmed, had a systolics in the 50s, heart rate in the 130s in RVR, a tense and distended abdomen, and dark blood and coffee grounds were seen coming from her PEG. Her labs were notable for a hemoglobin of 5 from a baseline of about 11. Her lactate was 8, and her AST, ALT were in the 1 to 2000s. She had no prior EGD or colonoscopy in our system. She was started on massive transfusion protocol, broad spectrum antibiotics, IV fluids, and then maxed out on Levophed. And then we were called to do a bedside EGD in the ICU. So this is what we found on EGD. So she had diffuse esophagitis, diffuse gastritis, ulcerations around her PEG internal bumper, which were actually not bleeding, a completely normal duodenal bulb. And then the interesting finding was she had a lot of dark blood in D2 with gangrenous appearing mucosa of the duodenum. So I have actually a picture on the next slide. Unfortunately, this is the only photo I have because this was a travel case and the cart was, the pictures weren't saving. So this is a blown up cell phone picture, but you can see here, there's kind of a lot of this like yellowish sloughing mucosa and mucus, which you could wash away and then see kind of down in the distal part of the D2. You can see the mucosa underlying is pretty purplish black, consistent with, it almost looked gangrenous, consistent with ischemia. So we ended up taking some random biopsies just to confirm our diagnosis and help kind of guide goals of care. And the pathology came back with necrotic tissue consistent with duodenal ischemia. So the management for this patient, she had a surgical consult. They recommended that further imaging wouldn't be likely to change her management and resection would be medically futile. She was transitioned to comfort measures and then unfortunately passed away 48 hours later. So I wanted to just talk really briefly on duodenal ischemia. I had never personally seen this before, and it's a fairly rare clinical entity. So I'll just talk a little bit about the discussion section of this case report. I really was only able to find case literature on this because it's so rare, but this was a paper published in 2020, similar to our patient upper GI bleeding secondary to duodenal ischemia. So I'll just give you guys a little background here. So duodenal ischemia is very rare because of the robust collateral blood supply to the duodenum, which I'll talk about in a minute. The etiologies kind of fall into the same buckets as etiologies of mesenteric ischemia in general. So you can have arterial and venous occlusion, vasoconstriction, and hypoperfusion. And then a couple of interesting points that this paper made as far as rarer causes of duodenal ischemia include transarterial chemoembolization, AAAs that kind of occlude or press on the branch vessels of the aorta. ERCPs can actually do this through periampullary hematomas. And then PEG tubes, I thought this is a really interesting one that you can actually, PEGs can serve as a lead point for gastroduodenal intussusceptions. So that's another kind of rare cause. Management is not very well delineated. If there are any surgeons on who want to comment on this at the end, I'd be interested to hear, but for the most part, what I saw, supportive care kind of predominated with hydration, hemodynamic support over surgery, which especially in the patient that I described would carry a really high morbidity and mortality given just how sick they are at baseline to develop duodenal ischemia. So I want to talk a little bit about the anatomy. I thought one of the interesting parts of doing this patient's endoscopy was that she had, her esophagus looked really bad, her stomach looked really bad, her duodenal bulb looked completely normal, and then D2 looked gangrenous. So I just wanted to kind of go over the blood supply of the duodenum and kind of figure out why that was. So just a review, this is pretty simple, but there are kind of two big branches of the aorta that supply the duodenum. One would be the celiac trunk, and you can see there that gives rise to the GDA, which we always look for in bleed cases when we go into the bulb. Ulcers in that area. And then that gives rise to the superior pancreatico-duodenal artery. So that would kind of supply more of the bulb area. And then down by the superior mesenteric artery, that's the one that gives off of the inferior pancreatico-duodenal artery, which would supply more of D2. So if you have any sort of predisposing like stenosis or severe calcification of the proximal SMA, coupled with something like a big hypoperfusing event, that could lead to more ischemia in the second portion of the duodenum, like we saw with some sparing of the bulb. So that brings me back to our case. Why did this all happen to this patient? So the predominant kind of thought is that she had some degree of arterial occlusion kind of underlying. So she had some recent imaging actually in Care Everywhere, unfortunately no pictures, but showed extensive atherosclerotic disease of the aorta and the branch vessels, and in particular mentioned a severe calcification of the proximal SMA. So if you go back to that photo, again, if you occlude the proximal SMA, you're going to have trouble perfusing the inferior pancreaticoduodenal artery. And then she also had AFib, which could lead to embolic phenomena, but less likely in this case. She certainly had a pretty high degree of hypoperfusion, as evidenced by her shock liver, her lactate, and her hypotension. Also had AFib with RVR, which led to likely poor cardiac output. Some degree of vasoconstriction. She obviously needed the LEPA-fed, but that could have contributed. And then she had a PEG. She didn't have gastroduodenal intussusception, but I just thought that was an interesting cause. And she kind of covers a lot of the major causes of duodenal ischemia just in her one case. So just a couple of quick learning points. So duodenal ischemia, again, is extremely rare due to robust collateral blood supply from the celiac axis and the SMA. The duodenal bulb in particular is supplied by the superior pancreaticoduodenal artery off the celiac, and D2 is supplied by the inferior off the SMA. Here are the etiologies that we covered, and then treatment is supportive care and prognosis is pretty poor. So I'll open it up for any questions or comments.
Thanks, Lauren. You know, it is exceptionally rare. I think I've seen, not quite in that part of the duodenum, maybe a little more proximally, but as a complication of TACE for embolization of HCC. And so they basically sent down and things to embolize the arteries. And so, but yeah, usually the teaching is duodenal ischemia is exceedingly rare because of that incredibly rich collateral circulation. It is good to, anytime we have a patient with any sort of ischemic disease of the GI tract, I'm always looking at the celiac trunk and the SMA to get a sense of those calcifications. They don't always call it. It's pretty fortunate they called it on the CT that you looked at in Care Everywhere, but they don't always call it. So it's good to sort of be aware of that. Any other comments? You will likely never see duodenal ischemia again, or hopefully not.
Yeah, I mean, I scoped this patient with Lauren. It was I was shocked. I mean, I said, "What the heck?" You know, I've been in the business, you know, over 40 years. I've never seen this, so it was pretty striking. Yeah. Did a great job. Nice discussion.
Excellent. All right, Lauren, part 2. See your slides, but don't hear you.
Okay, now can you hear me?
Yep, perfect.
Great. From the exotic to the mundane this morning. So I want to share a patient that I've taken care of actually within the last week. This is a 58-year-old veteran. He has a history of hypertension, GERD, H. pylori, gastritis, status post quad therapy with confirmed eradication. He's an active smoker with a 50-pack year history. Who actually presented to us for evaluation of iron deficiency anemia. He underwent an EGD and colonoscopy, but I always think about Dr. Waye whenever I'm finishing up my EGDs to make sure that I'm taking a very careful look on the way out, and that was done in this patient's case as well, because a lesion was actually seen on the patient's vocal fold as they were pulling out of the esophagus. Unfortunately, he was found to have laryngeal cancer, and ENT had planned to do a laryngectomy. And so they ended up consulting us in order to put in a prophylactic PEG, which went in without incident. A week later, we were consulted for pain and tenderness at the PEG site. And I went to evaluate the patient, and he was just septic. His white count had jumped from normal to 17 overnight. He had bandemia. His pressures were soft, and he was doubled over in agony, clutching his PEG tube and wouldn't let me anywhere near it. I had to beg him to let me even examine the site. It looked pretty nasty. It was very erythematous around the tube. This is actually not a real picture because my cell phone pictures are too blurry, but had horrible, what looked like cellulitis surrounding the tube in about a 9 to 10 centimeter diameter area, but also had significant fluctuance around the tube site itself, and really couldn't tolerate any touching or manipulating of the tube at all, even with administration of pain medication. So I was concerned about what was going on, and we ended up recommending the patient get imaging done. You can see here, there's no clear fluid collection, although maybe something is thinking about forming right in this area, but there's actually like significant inflammation of the rectus sheath. It looks like a pretty deep and angry infection. And you can see that the PEG terminates in the correct place. So it's just got me thinking about how many PEGs we put in and how excited we usually are to put one in. This patient, for a very reasonable indication, although oftentimes the consults we get for PEG placement are a little less short term. But I also wanted to go back and look at the literature and make sure that there was nothing that we had done during the case itself or in the subsequent care of the patient that might have put him at risk for becoming septic after PEG placement. And I looked back at the guidelines to see where the data for the things that we do for patients who get PEGs came from, and found the citation of this paper from 1999. So just a little bit of background. So the infection rates for PEGs before we were giving universal antibiotics during the cases varied actually pretty widely. If you look at the literature, anywhere from a reported 4 up to even 60% in a review paper from Endoscopy in 1995. In 1999, there was a multi-center prospective trial that looked at administration of antibiotics before PEG placement. It was a study based in Munster, Germany, like the cheese. It was 11 centers that were included in trial recruitment. You can see the details here, but basically 141 patients, half randomized to getting antibiotics, and actually not 90 patients, I'm sorry, 69 patients who were randomized to getting no antibiotics. The inclusion criteria included people who were over 18 years old, and enteral nutrition via PEG was required for at least 6 weeks period. So they had had NG2 placement for a minimum of 6 weeks before the PEGs had been put in. Exclusion criteria in this patient population: any signs of infection before PEG placement, any history of peritoneal malignancy, prior gastric surgery, active ulcer disease, gastric outlet obstruction for obvious reasons, any history of bowel obstruction, same reasons, and then any patients who had ever had any GI interventions in the past or had previously or were currently getting either radiation or chemotherapy. And all these patients had 15 French PEGs put in via the pull technique. Interestingly, they all used an antiseptic mouthwash before the PEGs were put in. That was a technique I hadn't seen before, but maybe we should be giving everybody Listerine. At least they'd have good breath when they woke up. No local antibiotics were given at the PEG site for any of the patients. And then the outcomes were local and systemic infections actually at day 4 and day 10 after the procedures. So you can see here that the patients who had no antibiotics had pretty significantly higher rates of infection at both day 4 and day 10. You know, the demographics in this study were actually quite important for the people that we end up putting PEGs into. The mean age was 74 years old, which feels about right. The BMIs were 21. The indication for PEGs in 65% of the cases were neurologic damage, and in 30% of the cases were malignancy, like the patient I had seen myself. Similar rates of comorbidities, including diabetes, alcohol abuse, cardiovascular disease, heart failure, COPD. Actually, 8.4% of the patients who did not get antibiotics and 2.9% of the patients who did actually died during the 10-day observation period. 2 patients died in the no antibiotics group secondary to systemic infection, actually one of pneumonia and the other one of sepsis of unclear etiology. And another thing that I thought was very interesting is that when they did a subgroup analysis of the people who had PEGs put in, specifically like our patient, because they had malignancy, The outcomes were actually even more marked, with greater variations and higher rates of infection in the patients who didn't get antibiotics versus those who did. 38.7% no antibiotics versus 5.8% of the patients who had prophylactic antibiotics given at the time of PEG placement. The other thing I thought was very interesting is that they did cost analysis to look at whether it was actually cost effective to be giving every single patient who gets a PEG put in antibiotics. And what they found is that it costs $16 per patient for the patient who did not get antibiotics when you count in all of the antibiotics they ended up needing to get if they got an infection afterward, versus $17 per patient in the patients who did. So a $1 differential per patient. So essentially, antibiotic prophylaxis with 1 gram of ceftriaxone, which is what we all do, decreases post-PEG placement infections, both local and systemic, seems to be cost efficient. There was actually a follow-up study to this one that looked at 17 prospective placebo-controlled studies where they looked at medication costs and again didn't find that there was much of a difference, and that the average cost of antibiotics per patient was approximately $13 per patient, with an average cost savings of $77 per PEG, which I thought was interesting. And for those of us who are hoping to get out of the business of putting in PEGs altogether, because our friends in IR are happy to help us and put them in, there was actually a recent meta-analysis that was published 2 years ago that looked at 16 studies comparing the PEGs that we put in versus the PEGs that IR puts in, and found that there were no differences in mortality or infectious complications, but significantly different decreased rates of tube-related complications in the tubes placed by GI. So I don't think we're off the hook anytime soon. So,
what happened to the patient?
Yeah, so going back to our patient. So interestingly enough, because there was no quote unquote drainable collection on the CT abdomen pelvis, infectious disease was consulted and recommended clindamycin, which seemed a gentle option to me for somebody who was that sick. But sure enough, actually, with 24 hours, he had dramatically improved. His leukocytosis resolved almost entirely. I went back to see him in the morning. I was able to loosen his bumper without him wanting to punch me in the face. And out came about 40 to 50 cc's of pus around the tube, just exploded. And as soon as that happened, he started to feel much better, with almost total clinical resolve in about 3 to 4 days after that.
Yeah. I think you like that.
On the CAT scan, you can see there's no stomach wall between the flange of the tube and the abdominal wall.
Go back to that.
Don't really know how to stuck it there. Like they get a bus to somewhere like in the middle of nowhere and they all.
Yes. Yeah. You know, I think one of the things that was interesting was how sick this patient got, which I had not seen before. And it just made me think about, you know, none of us, or at least in my limited 3-year experience during fellowship, we don't tend to be super excited to be putting PEGs in, especially because a lot of the people we're putting them into perhaps may not have mortality benefit. But this guy really is the perfect candidate for somebody who needs enteral access and who, by all accounts, should have done very well, did get prophylactic antibiotics. And so I was just thinking about sort of what we could have potentially done differently, if anything. And luckily he improved with pretty minimal antibiotic therapy.
Lauren, in your reading, was there anything about using vancomycin in MRSA colonized patients?
Yeah, so it's a very good question. After this study was done in 1999, there was a follow-up study done in 2000 where they randomized people not to no antibiotics, but to different antibiotic therapies. I would imagine others know better than I do, but they were trying to figure out whether ceftriaxone was a reasonable choice and whether it was sufficient to just give 1 dose 30 minutes prior to PEG placement. In other words, like, do people benefit from a 2 to 4 day course of antibiotics after PEG placement? And what's the optimal antibiotic choice? I don't think that they actually looked at vanc specifically, but they did look at different generations of the cephalosporins, and it confirmed this paper that ceftriaxone seems to hit that sweet spot between cost efficiency, but also significant enough coverage to prevent infection after antibiotics. So no, but I think it's a well taken point, especially given our population and increasing rates of resistant infection, especially in those who have been hospitalized for a while, which is very often, at least on the consult service, who we're putting pegs into.
I always find the era of studies, which 1999 isn't that long ago, where they had a placebo arm to an antibiotic prophylaxis study. Just sort of like, how was that even acceptable? You know, I'm surprised on the placebo side, on the antibiotic side, that the rate of infections was still 10%, because I would say clinically we don't see that. You know, I came from a program in fellowship where we did a lot of outpatient pegs, and they all did great. And that's just a very high number on the placebo side. I mean, I think peg site infections are generally pretty rare. If they happen early, typically, like it did for this patient. You know, Bridgen and Sally, when she was here, had been working on it now with Josh, and then I've sort of come in to help out a little bit as well, working on a project about pegs and peg management and peg infections and things like that. And it's a QI effort that involves a lot of nursing care, as well as GI. And one of the things is when are we giving patients antibiotics? Now, the typical timing that I see in endoscopy is we like hang the antibiotics as they're pushing the propofol. And the likelihood of any molecules of that antibiotic getting to the skin site is like pretty minimal, considering you're about to stick them like 4 minutes later. And it really should be half an hour to an hour ahead of time, like circulation time and stuff like that makes sense. And so we really should be trying to give patients their antibiotics in the pre-op area before they come in, and not sort of concurrent with propofol.
Satish, this is actually a question I've like always had, because I think 4 minutes is maybe generous. Like it might be 2 minutes between when we're like putting the peg in and whenever the antibiotics go in. So the half-life of ceftriaxone is like 9 hours. So is there any reason that we shouldn't just be telling teams to give it on the floor? This 30 minutes thing seems quite arbitrary, just given the like, you know, mechanism of action of the drug. You know,
I'm sure the surgeons can comment on this more. There is a boatload of literature, I think, particularly in the surgical world, about antibiotic prophylaxis and surgical site infections. And it's really generally within 1 hour. And that's a major quality metric, I think, that occurs in the surgical world. Even though the half-life is 9 hours, you're really looking for a peak concentration. And I think that because you're sort of you could be theoretically introducing a very high concentration of bacteria into the bloodstream in a very short period of time. So I think that's where peak effect is probably really beneficial. And so, and the other thing is, as you very well know, timing these things is near impossible for inpatients as best as we try to. So I think the best bet is really when they're in the PACU area before the procedure, get them their antibiotics there. But other than that, these things do happen, and there's probably nothing you really did wrong.
Were you surprised about the timing? So I from everything I read, the vast majority of post-PEG complications, including infection, will happen in the first 4 days after the procedure. This guy actually had had a PEG put in a bit more than a week before we were consulted. Now, I think he probably was sick for 2 days before anybody picked it up.
Yeah.
But
I think within a week, it's still pretty fresh. And you're right, that didn't happen on day 6 or day 7. That had been brewing already. He was already pretty septic, which is so rare for basically cellulitis. He's basically sepsis from cellulitis, right? Which is kind of bonkers. So chances are he had been simmering and brewing for a while. So the first handful of days is when you would see it. If you told me this happened a month out, that would be really bizarre. Like that should never happen. Any other comments?
I had one more question for the advanced team. When we see a PEG site infection, obviously you can see it on the CAT scan, this gentleman had a huge amount of subcutaneous and muscular swelling. And I think a lot of his discomfort was actually that the bumper was so tight to his skin because of all that local inflammation. But then I was like very worried about manipulating the area, given how angry it looked and how uncomfortable he was. And sure enough, as soon as I touched it, like a ton of pus flew out. Is there any concern with touching it? Was it the right thing to try to cool him off for a little bit before we started manipulating the tube, or does it not matter?
I don't think it matters a whole lot. Your citrix, I kind of trying to bounce off the screen there. I don't think it matters a whole lot about trying to loosen at that time. Personally, one of my soapboxes is that I think we make our pegs too tight on the first day to begin with. We have them flat on their back, and then we put that bumper really tight. And then when they go to sit up at 45 degrees for aspiration precautions, their belly falls forward and is insanely tight against the bumper. So you always have that bumper about 1 centimeter off the skin, because the patient's never going to be supine ever again like that, especially these PEG patients, right? They're always going to be upright for feeding. And so I always have 1 centimeter gap between the skin and the bumper, and many other GI attendings tell me I'm crazy. But when you sit them up, their abdominal wall is flush against that PEG bumper, and it's not as tight. And it reduces the rate of buried bumper. And I think patients are infinitely more comfortable, because I'll tell you, if you're doing outpatient PEGs, no one is loosening that PEG the next day. They are home, like complaining about how tight this PEG is. So I always give myself 1 centimeter, if they're really kind of obese, even more than that. Because again, when you sit them up, think about where that pannus is going to hit against that bumper.
Yeah, I did a whole bunch of outpatient PEGs, and I do the exact same thing for the exact same reason. And I think it's the right approach. So the other, not for now, because we got other things to do today, but another day, there's a really lively Twitter poll. This is not very scientific, right? But going on about the timing of starting feeds or anything after gastrostomy tube placement. So it'd be another topic for another day. But that poll is like all over the place. And it has everything to do with like where you trained and who taught you and what they told you, and you never learn anything else after that. So another day, another topic.
Thank you, Lauren. All right, Nick, what do you got?
All right. So this is part 2 of a series that I started now 2 weeks ago, since we skipped a week, but I will explain the background for anyone who wasn't here or just doesn't remember. But this patient initially came in, she was a 58-year-old female, history of alcohol use disorder, and she had initial presentation of necrotizing pancreatitis related to alcohol. So on her initial admit scan, you can see this pancreatic necrosis that subsequently evolved. It became an acute necrotic collection. She actually had infected necrosis and was treated at this stage with antibiotics because it was too early to drain, but then presented 3 weeks later with walled-off necrosis that was infected. And so we actually took her for an EOS-guided gastrostomy. And that's what I showed last time. So this is an EOS image of the collection. You can see a large necrotic collection with partially fluid and solid material. And this is after lumen-opposing metal stent placement after the gastrostomy. And then we didn't do any necrosectomy on this initial presentation to allow the lumen-opposing metal stent to sort of set in. And then we brought her back 3 days later for a necrosectomy. This was the final fluoro shot of the gastrostomy. We did put double pigtails through the lumen-opposing metal stent as well, and a nasojejunal feeding tube for nutrition. So here is the next endoscopy and necrosectomy. So this is the gastrostomy site. You can see the lumen-opposing metal stent with the plastic double pigtails through it. The double pigtails are removed. Kind of zoom forward there to get to the meat of it. And then the gastrostomy tract is entered. And what you see immediately is a cyst cavity with pus and this pasty adherent necrotic material. You can see the stringy component. We start out by just lavaging it and cleaning it. Sometimes we'll use even some dilute hydrogen peroxide here to sort of sterilize, and there's sort of some effervescence in the hydrogen peroxide that loosens things up. And then we begin necrosectomy. So this is a little bit of a dealer's choice procedure. Here we're using, this is actually a biliary stone extraction basket. And you see the consistency of this stuff. It's kind of variable depending on the patient, and the tools we use might depend on just the way the material looks and what works. The basket happened to work really well here, but you'll actually see a few different things that we tried. This is a snare. The snare ends up not working too well, unfortunately. And of course, this whole video is sped up into like 2 to 4 minutes, but these procedures can go on, you know, a variable amount of time depending on sort of how successful we're doing and time in the day and endoscopist fatigue level. But anywhere from an hour to a couple hours, 3 hours. We try the Rothnet. The Rothnet always seems intellectually like it might work, but then once you get it out, you realize it's not really going to work at all. And also, you have to bring it out essentially through the mouth to get to clean up the net. And so that's just really inconvenient. Mostly we just deposit the necrotic material in the stomach with the other tools. Is much easier. And then what tools we use maybe on the same patient on different days might even vary. This material evolves over time throughout the process. So back to the basket, again, just huge success with the basket here. And we just proceed with necrosectomy.
And that looks like fat necrosis, no?
Yeah, it was really more solid type material. And here's the final result after this one necrosectomy. You can see a lot of the cyst wall is cleared out and visible and viable. A lot of the necrotic material is gone. The pus is gone. This lumen-opposing metal stent is removed at this point, as at this point there's a clear connection between the cyst and the stomach, and the lumen-opposing metal stent is just at risk of causing complications at this point, like ulceration. One more look inside, and actually, again, this was just a great result after one necrosectomy. There's still a little bit of material. And then in order to keep the tract open, because we removed the lumen-opposing metal stent, but we still want things to drain, double pigtail plastic stents are placed through here. And 4 pigtail stents are placed. And the patient did amazingly well after this. So she was hospitalized. This was her second hospitalization for pancreatitis. She was hospitalized on initial presentation. Then she came back 3 weeks later with the walled-off necrosis. And we did the 1 endoscopic cyst gastrostomy and then 1 necrosectomy. And then she went home and she was actually better. And then she came back 1 month later as an outpatient. And this is the brief follow-up endoscopy. So these are the double pigtail stents have mostly been removed except for 1. And this is just to demonstrate the vast improvement in the cavity. The cavity essentially can't even be entered at this point. So it's collapsed to the point where there's almost nothing left. This is all we could really see upon trying to enter it. So it's a very dramatic response, and we'll see it on imaging as well.
Nick, where's the metal stent?
The metal stent we pulled. Usually at some point during this process, we pull it because it just leaves the patient at risk of having complications from the metal, and the tract stays open. And that's where we just use the double pigtails to keep it open. So this is the evolution of the imaging. You can see pre-necrosectomy with the walled-off necrosis on the left. Immediately post-necrosectomy, it's already 90% collapsed. And then on follow-up, this is several months later, there's no visible collection at all. And this is a coronal view, which also demonstrates it pretty well. And all the way on the right, you can see there's actually just nothing left. So last time we talked about just sort of basics of acute pancreatitis, the difference between interstitial pancreatitis and necrotizing pancreatitis. Our patient is on the right here with the evolution from an acute necrotic collection to walled-off necrosis. And we talked about here, walled-off necrosis is a late complication of necrotizing pancreatitis. And indications for drainage include infection, obstruction, either enteral or biliary, or this sort of persistent unwellness with pain, inability to eat, just not doing well. And that the optimal treatment is minimally invasive. And so that is what I want to focus on today. So there've actually been multiple randomized controlled trials, because the traditional treatment for this was an open surgical necrosectomy, which is a very morbid procedure, and outcomes are not good. So there have been multiple randomized controlled trials comparing minimally invasive approaches such as endoscopy, as we showed, percutaneous drainage, some combination of those. The other thing to mention is VARD, which is still a surgical treatment, but much less invasive, which is video-assisted retroperitoneal debridement, where a percutaneous tract, usually using a drain tract placed by IR, is dilated, and then these surgeons can do debridement through that tract. And that's useful sometimes in combination with our endoscopic approach, depending on the location of the collection. If it's a large retroperitoneal collection, it may not be as accessible endoscopically. So there is a meta-analysis of these trials, and basically all of them consistently show better outcomes with minimally invasive treatment of these infected necrotic collections. Mortality comparing endoscopy and surgery is the same, but endoscopy has lower rates of new onset multi-organ failure, lower rates of pancreatic fistulas, and that's probably the most dramatic outcome, and shorter mean hospital stays. I'll also just note that the mean hospital stay for this disease is very long. In these studies, the mean hospital stay was 31 days. And sometimes medicine teams are less comfortable with that. They don't necessarily understand how severe this disease is, but I think it just indicates how bad this problem is. And so really endoscopy comes out on top in all these studies, and that's why that is now the standard of care for these patients. Any thoughts?
I do. It's really nice. The series of both cases, both weeks was really nice. So thanks very much for putting that together so really clearly, and the video is really good. So the question has to do with nutrition. So you want to talk about feeding, because it actually came up on the GI service this week. So if you've got this lumen opposing metal stent and a connection directly into the pancreas, how do you deal with feeding during the time that the stent is in, and then even after you pulled it?
That's a very good question. So just to even back it up more, because we also addressed this last week, is that one of the most important things in pancreatitis outcomes is enteral nutrition. And we harp on this continuously. There are clear randomized controlled trials indicating that enteral nutrition is superior to parenteral nutrition for outcomes in acute pancreatitis. And so we're always trying to get the patient nutrition in one way or another. If can't tolerate PO, we either place a nasogastric tube or a nasojejunal tube. Either is acceptable. There's no real difference between those. If the patient can tolerate an NG tube, that's just simpler because it doesn't require an endoscopy. If they can't tolerate gastric feeding, then we place a post-pyloric tube. In these cases, it's pretty much standard. We have our protocol. We go in. When we do the initial cyst gastrostomy, we place an NJ tube at the same time. And it's not necessarily because they can't eat with the cyst gastrostomy. It's just that usually these patients are so sick they need tube feeds at this point. And so we immediately start feeding them through the nasojejunal tube. And then as they get better, they actually can eat with the cyst gastrostomy stent in place. It's just the nature of the flow of things, as things tend to flow out of the cyst into the stomach. And we don't really see that there's like food or anything contaminating backwards into the cyst. There's just no gradient for things to go that way. So it's actually not a problem.
Yeah, the tract is relatively small, 15 to 20 millimeters, and then we have pigtails in. So in general, and then based on the physics and dynamics of how food sits, it tends to, it seems like it should just pour into this open cavity, but it doesn't, right? And then if you start to think about the angles, lesser curve, very proximal very often, pigtails in there, small opening, peristalsis. And so whatever might go in would probably just flow back out again. It's a little liquid or something like that. But yeah, they certainly can't eat. This hospital has a little bit of a parenteral nutrition problem, and it's exceedingly frustrating, but slowly trying to chip away at that.
And then the latest development, sort of hot off the presses, is yesterday we received approval from, I guess, materials management in the hospital to obtain a new device called an endorotor. This is, they call it, it's defined as a morcellator. Basically, it's like a weed whacker or a roto-rooter. It's a small probe that that's attached to a generator, goes through the scope, and you can insert it into the cavity. And it is highly efficient at grabbing, pulling, and sucking out the necrotic debris much more efficiently and effectively than what Nick was showing with our standard endoscopic tools. There's some early data coming out showing that patients who undergo this may be able to reduce the number of necrosectomy sessions by up to 50%. And as Nick has mentioned, these patients are in the hospital a long time. You know, it's not unusual for us to be doing 5-6 rounds of necrosectomy. I think we have the patient we have in the hospital now, I think he's had 10 rounds of necrosectomy. We have another patient's had 9. So if we can, and we did in order to sort of get approval for this, we had to do a cost analysis, and, you know, we calculated the estimated savings in terms of cost of hospitalization and length of stay. And the savings are significant, and basically, you do this on one patient and it basically pays for the system itself. So hopefully we'll have an opportunity to get it in quickly and certainly demonstrate it once we start using it.
It's to sort of change the way we think about the disease. I mean, I know, you know, that we're sort of onto something when the surgeons are really happy, like, oh, great, you take this patient, because there was not a lot of excitement for all the other things that have been innovated between stents and resections and whatnot. But this is one that the open surgical group is a pretty, it's a pretty morbid procedure. But I'm excited to see endorotor come into play here.